Hello, everybody, and welcome to the ROSA Worldwide Webinar Series. My name is Mike Reed. I'm the Chief Scientist at ROSA. Please look forward to upcoming webinars by checking the ROSA website or checking your email for periodic announcements. During today's webinar, if you'd like to ask a question of today's speakers, feel free to enter a question in the Q&A panel at the bottom of the screen. There's a little button you can push to enter questions. I'd like to introduce today's speakers. So our first speaker is going to be David Turner, who is a distinguished scientist in the Department of Clinical Pharmacology at Genentech. The second speaker will be Joseph Chen, Senior Principal Scientist in the Clinical Pharmacology Oncology Group at Genentech. There will be a couple of additional speakers available to answer questions. That'll be Russ Wada, who's a principal consultant at Quantex Consulting, and Phyllis Chan, who is a distinguished scientist at Genentech and co-chair of the ISOP Special Interest Group for Model-Based Meta-Analysis. So with that, I'd like to welcome today's speakers, and you're welcome to get started.
Hi, hello, I'm David Turner. Thank you for the intro, Mike, and thank you to everyone for attending our webinar today. On behalf of my co-authors, I'm presenting our meta-analysis framework that we developed for benchmarking efficacy outcomes in early phase lung cancer studies. So this work was originally published in CPT PSP Journal in 2023, and please note, this study was funded by GSK and was a collaboration between GSK and our vendor, Certara, while I was an employee with GSK. Now I'm currently employed with Genentech, but this work was not performed at Genentech. And more complete details on this framework and other key results can be found in this original publication. So to provide some brief background on the motivation for this work, it's helpful to briefly understand some of the current landscape in lung cancer. So over recent years, PD-1 inhibitors have become a standard frontline treatment for non-small cell lung cancer, or mNSCLC. However, not all patients respond to these treatments, and so there's still a need for development of novel therapies and combinations. New treatments for lung cancer are often initially evaluated in combination with PD-1 inhibitors in single-arm studies, which can sometimes make it difficult to understand the clinical signals from these studies. So the objective of our framework was to develop a more precise way to predict the added benefit of novel treatment agents on top of PD-1 inhibitors by coming up with a system for benchmarking efficacy against historical anti-PD-1 controls, either in lieu of or to supplement randomized control data. The overall goal was to improve our go-no-go decision-making early in clinical development to increase our overall development efficiency. So we used a model-based meta-analysis, or MBMA, approach to combine aggregate and subgroup level patient data from multiple published studies of two of the key standard of care PD-1 targeted agents, Nivo and Pembro. The MBMA captures different treatment effects and can be used to simulate treatment outcomes, accounting for the influence of these patient factors. As illustrated by this overall schematic here, separate ORR and OS models were developed through a stepwise process to screen for different patient factors. The analyses were based on the standard of care data from prior published clinical trials, from which the response data and survival curves were extracted and digitized. So as far as our data set, we were focused mostly on the data generated from 15 specific clinical trials, 8 of which contained Pembro, and 7 which included Nivo. We also had included data from the relevant comparator arms of these clinical trials, which included chemotherapy combinations. As you can see on the graphic on the right, we were able to capture data across different development phases, different lines of treatment, treatment types, different histologies of lung cancer. So we'll start first with describing our response rate model and highlight some of the key factors influencing treatment efficacy in this space. Our response rate model was relatively straightforward, a logistic regression model, which included both trial and arm or subgroup level covariates. A forest plot of the observed response data is illustrated on the right, with the blue squares representing the actual recorded values from the literature. The font size on this graphic is obviously a little bit small to read, but a couple points I want to convey here is that one, we have many more than 15 data points from across these trials once we start digging further into the individual arm level and subgroup level results. And two, the heterogeneity across these different subgroups is quite high. Basically, you can see there's substantial variability in response depending on the particular trial or treatment arm. Now, sometimes high variability like this can affect the interpretation of a meta-analysis, but also having this level of variability in the underlying data illustrates how challenging it is in general to benchmark against external data in the space without accounting for potential factors that might be influencing the response variability. A key aspect to this analysis is including the right data so that we could discriminate these covariate effects within a study at the subgroup level. So basically taking this variability from an unknown random effect to a known fixed effect. So overall, our meta-analysis demonstrates a correlation between response rate and a few key covariates. Specifically, the odds ratio for squamous versus non-squamous histology is 1.02, indicating a very slight increase in response for squamous histology. Though it had a marginal effect, histology was included in the model a priori based on feedback we had received from our clinical team. Additionally, the odds ratio for a 10% increase in PD-L1 TPS score is 1.2, suggesting that higher PD-L1 tumor expression is associated with improved response, which is more or less consistent with the current knowledge in the field and some of the individual trial results. However, a unique aspect of this analysis here is that we modeled PD-L1 expression as a continuous variable instead of a categorical input. To do this, we had to impute values for some of the categorical PD-L1 data, but we have some data in the original publication supporting that this relationship is more precisely captured by a continuous input. Now, the forest plot on the bottom portion of the slide visually represents these model results depicting odds ratios and confidence intervals for each covariate. The plot highlights the size of the impact of each factor on response, with PD-L1 expression showing the more pronounced effect compared to our histology effect, which is almost negligible. Also, the treatment type, whether it was chemo alone or PD-1 combination, influenced response rates, again, consistent with some of the established knowledge in this treatment space. Overall, this information is important to provide a more quantitative and systematic understanding of these differential effects of patient characteristics on treatment outcomes. So this next slide illustrates some goodness of fit plots for the response model. Each point on the graph represents an individual subgroup or trial level result, plotting the observed value against the model's predicted response rate, with the size of the data point reflecting the number of patients. The model itself was also weighted according to the sample size as well. And the plot on the left discriminates the model results based on treatment modality, whereas the graph on the right is colored by line of treatment. Overall, the proximity of these points to the line of identity indicates an adequate model performance, as the predictions closely approximate our actual response rate data. This consistency across different subgroups also highlights the model's reliability in capturing some of the nuances of treatment response and describing sources of the heterogeneity that we noted earlier in the observed data. So next, we'll do a brief overview on the overall survival or OS model methods and results. So we'll start with a quick primer on hazard, risk, and survival, focusing on overall survival as our event of interest in this model. Generally speaking, in the context of a time to event analysis, the hazard is the immediate probability of an event occurring, like death at any given moment. So you can think of it as sort of like a ticking clock of risk. Now, overall risk takes a broader view and represents the cumulative chance of this event happening over time. And finally, we can translate these concepts to model survival outcomes, which is simply a measure of the duration of time until the event occurs and is a function of our cumulative risk. So on this next slide, I'm sharing some of the digitized Kaplan-Meier plot for pembro trials, which I think provides some insights into the type of data observed across these studies and subgroups. The curves, again, were directly digitized from plots found in the literature, with the data captured at 1-month intervals along the survival curve. Now, while a typical time-to-event analysis benefits from having individual patient-level data, in our study, we faced the challenge of relying on aggregate data extracted from these published sources, which requires different methods for analysis. One other thing to note here is that similar to the response data shown earlier, there is significant heterogeneity in survival outcomes across the different studies and subgroups. This variability obviously requires careful consideration when interpreting the data for benchmarking, and again, also highlights the importance of capturing any known effects of trial characteristics across these populations. On this next slide, we present similar digitized plots for the Nivo studies as a point of reference. Based on this visual summary, again, we see a lot of variability in survival outcomes across the different trials, including Nivo and chemo comparators. Now, in the early versions of our models, we actually explored differences between Nivo and Pembro, but found these two to be interchangeable based on this current data set. So next, we'll briefly review the semi-parametric method used for modeling the aggregate survival data, which I think is one of the more novel and perhaps interesting aspects of the study, and hopefully can find other applications outside of this work. The approach we use combines flexibility of non-parametric methods with the structure of parametric models, allowing us to analyze the aggregate survival data without relying on individual patient records. As mentioned, we began by digitizing survival curves to estimate probabilities across time points. Then to model this data, we employed a piecewise model that describes the baseline survival function, capturing the conditional probability of death over these discrete 1-month intervals in a flexible manner. This method allows us for the adjustment of the reference curve by a set of covariates and also incorporation of random effects. The overall concept here is very similar to a Cox proportional hazards model and allowed us to account for heterogeneity across these different studies and patient subgroups. So in an effort to make this presentation perhaps a little more generally useful to the broader community, we're sharing some brief snapshots of non-mem code here to illustrate how this model was implemented. Some items to highlight here are the data inputs, which include a time variable, T-last variable, which reflects the prior time point and is used for defining these 1-month intervals in the data. And here the dependent variable, or DV, is the digitized survival fraction for each subgroup or trial. You can see on the left how the conditional probability is actually modeled by a series of nested if functions, with each theta representing a logic transform difference in survival between two intervals. On this next slide, you can see a snapshot of how covariates and random effects were implemented within the code. The term highlighted in red is essentially the log transform hazard ratio, which is used to scale the non-parametric reference survival curve by our vector of covariate and random effects. And as we described on the prior slide, IPRED is the modeled conditional probability of death at each discrete time interval. So this next slide highlights some of our exploratory plots generated prior to modeling for looking at relationships between response rates and overall survival. One of the key objectives here was linking these early interim endpoints to longer-term outcomes. The plot shown on the left is the median OS versus response, and the plot on the right is the 12-month milestone survival rate versus response. And overall, I hope you can appreciate from these exploratory plots that there is, in fact, a positive relationship between response and OS endpoints. However, a key finding from this exploratory look is that we also observe that this relationship varies depending on treatment modality. For example, PD-1 inhibitors seemingly provide a durability boost, enhancing the survival rates more significantly than chemo alone at comparable response rate. And we believe this highlights the importance of considering the type of therapy when interpreting the response rate data and linking that to OS for benchmarking. A brief summary of the survival model results is presented here. We found the most influential covariates to be the response rate, line of treatment, and histology. And based on the exploratory analysis I just shared, we estimated separate ORR to OS relationships in the actual full model based on treatment modality. One interesting finding here is that we did not separately identify PD-L1 expression status as a predictor for OS, but this was already accounted for and sort of baked into the response rates, which were included in the OS model. So now that we've briefly reviewed some of the details of these models, let's talk about how we can apply them for drug development decisions. Now, for the purposes of our paper and this presentation, I need to keep specific use cases confidential, but we can illustrate how the models can be applied through these hypothetical scenarios. To help make this more generally useful, we simulated 3 different scenarios. First, we have a base case population, which serves as our reference group and offers a somewhat balanced perspective on patient characteristics. Next, we introduce a low responder population. This group has a higher prevalence of non-squamous histology and lower levels of PD-L1 expression. And lastly, the high responder population represents a more optimistic scenario. This includes a higher percentage of squamous histology and higher average PD-L1 expression. Now, using these 3 populations, we can apply the MBMA framework to forecast a likely range for what a PD-1 plus chemo combo efficacy may have been in a similar set of patients with comparable disease characteristics, in this case, a hypothetical phase 3 study. And this approach is often referred to as a synthetic control arm. So we simulated these hypothetical phase 3 outcomes for each defined population. The probability to demonstrate a target hazard ratio was calculated for a novel treatment X cohort with a hypothetical phase 1 response rates ranging from 35 to 50%. For each scenario, 1,000 simulations of the OS hazard ratio were performed, incorporating the sample size of our phase 1 study and uncertainty in the model projections for predicting the phase 3 outcomes. The output shown on the slide here represents a visual representation of those results and how different levels of response can affect the predicted probability of success for achieving specific phase 3 outcomes, thereby aiding in clinical decision-making and strategy optimization when we need to make a go, no-go decision based on early phase 1 data. Now, as we move to the low responder scenario, you can see the same range of response rates gives us a theoretically higher chance of attaining a favorable phase 3 hazard ratio. And lastly, the results from the high responder scenario shows a much lower likelihood of phase 3 success across the same range of phase 1 outcomes for our novel treatment. This is because the efficacy bar will be inherently higher in this particular population. Now, if you have a similar patient population as one of these 3 scenarios, what's nice about this prediction nomogram is that you wouldn't necessarily need to rerun the models, but could directly estimate a probability of phase 3 success from these plots. So to briefly conclude here, overall, the strategy of incorporating historical data into quantitative decision-making provides a more consistent and data-backed approach for go, no-go decisions by incorporating specific factors that can influence the efficacy. This framework we developed was ultimately designed to help us make better development decisions based on early phase clinical trials. And as far as I'm aware, expansion of the MBMA framework is still ongoing at GSK. And the next story from my colleague Joseph from Genentech will describe another interesting application of these methods in other decision-making situations. So thank you for your attention today, and Russ and I are happy to answer questions at the end.
Okay, David, if you can unshare, let Joseph share. Yep, looks great, Joseph.
Great, thank you so much. I'll get started. My name is Joseph Chen, and thank you for the introduction earlier, Mike. Today, I'll be presenting on behalf of my team members and collaborators on model-based meta-analysis for the Ipsos trial in platinum-ineligible non-small cell lung cancer patients. And just like David alluded to, this would be a case example or application of the methods that he went over. So the Ipsos trial was a phase 3 randomized study that evaluated atezolizumab, a PD-L1 inhibitor, versus single agent chemotherapy in patients that had treatment naive non-small cell lung cancer that was locally advanced or metastatic. The purpose of this trial was to address a treatment gap. So typically, in these patients, the first line therapy is platinum doublet therapy. But in the Ipsos population, these patients were platinum ineligible due to frailty. So on the left box here, it shows the enrollment criteria. These patients were platinum ineligible, had ECOG performance status scores of 2 or 3. And just to briefly explain some background for those that aren't familiar with oncology, ECOG performance status is a score that rates a patient's functional status and can be kind of thought of as maybe analogous to frailty. ECOG performance status score of 0 means they have normal function. If the score is higher, that means patients are more functionally impaired. And so ECOG performance status patients of 2 or 3 typically cannot tolerate platinum-based therapy. Patients who were ECOG performance status of 0 or 1 were permitted on study if they were of advanced age, so age greater than 70, or other sorts of substantial comorbidities or contraindications to platinum chemotherapy. One other thing to note about the Ipsos trial as well is for the control arm that had single investigator's choice of single agent chemotherapy, the study only allowed vinorelbine or gemcitabine, and that'll be important later as I discuss the MBMA analysis. So the study did meet its primary endpoint of overall survival. There was a stratified hazard ratio of 0.78, which was significant. And on the right, it shows the Kaplan-Meier survival probability curves. The blue is a single agent chemo, and the red is atezo, and clearly it shows that the atezolizumab arm had treatment benefit. To also provide some background, there are 2 organizations that provide treatment guideline recommendations for oncology. So one is the National Comprehensive Cancer Network, or NCCN, and it's a nonprofit organization that helps publishes treatment guidelines and helps guide medical practice in the United States. Per the NCCN guidelines for non-small cell lung cancer treatment for patients who are ECOG performance status of 2 and greater, the preferred and for these patients, they're platinum ineligible. The following monotherapies are recommended: docetaxel, paclitaxel, gemcitabine, pemetrexed, and vinorelbine. ESMO is a similar such organization, but in Europe, they also provide treatment guidelines. And for the ESMO list for this population, it's quite similar. It's docetaxel, gemcitabine, pemetrexed, or vinorelbine. So as you can already start to see, in our study, the investigators were allowed to use gemcitabine or vinorelbine, but there are these other single-agent chemotherapies that could have been used for this patient population as well. So that presents a gap. Like mentioned in the prior slide, there were other potential chemotherapies that could have been used. And so the question arises of, would atezolizumab single agent in patients who are platinum eligible still have a significant treatment benefit if the other NCCN or ESMO guideline therapies were also included? And so this gap created an opportunity that MBMA could potentially address. So the MBMA analysis objectives were as such: to analyze patient responses in the treatment of first-line non-small cell lung cancer in selected monotherapy trials with patient populations similar to Ipsos, in order to see whether or not Ipsos control is non-inferior to historical trials in which other single-agent chemotherapies could have been used. The first step of this model-based meta-analysis, and probably arguably one of the more labor-intensive steps, is the literature search method, to build the analysis database. And so the literature search was conducted to identify studies that had populations that matched the Ipsos trials with patients that use monotherapy treatments described by the guidelines I went over earlier. The search included articles up to September 18, 2023, and the criteria I've listed here. The population was chemo naive, advanced or metastatic non-small cell lung cancer who are platinum ineligible. The interventions that were included in the search was paclitaxel, docetaxel, gemcitabine, pemetrexed, or vinorelbine as monotherapies. And the outcome that was digitized and extracted for the model-based meta-analysis was Kaplan-Meier overall survival curves. So for the actual MBMA methods, So this entire presentation is an application of the methods that David mentioned earlier. And so David went into a little bit more detail in regards to this method, and I'll touch upon it at a high level. So the MBMA method would model the digitized OS curves using what I'll call the Turner non-parametric method, which estimates first a reference OS curves and then shifts this OS curve to match the individual studies using random effects and other covariates. In terms of our covariate analysis, what we did was, since this analysis specifically was using summary level aggregate data from each of these studies, another publication, Lee et al. 2017, was actually a meta-analysis which used individual data, which allows much more robust evaluation of covariates. So this publication was also in non-small cell, or it was also in lung cancer. And so we used the baseline prognostic factors that were identified in Lee 2017 to help give us a hint and guide our search. Then the next step was to use the model estimates, the covariate effect estimates from the Lee 2017, and then calculate the relative risk of each of the trial populations to give us, again, a clue to see which baseline prognostic factors would have the highest influence. And then lastly, we would include the covariates in our model and evaluate the objective function value change. And if it was significant, it would remain in the model with the alpha cutoff of 0.01. Once we arrived at final model, it would be used then to estimate the hazard ratio between the Ipsos control arm and the various comparators of interest. So won't go into this in detail. It's quite similar to the slide that David showed earlier, but I just want to reiterate two key points. First, this non-parametric method estimated in a piecewise fashion a reference curve by evaluating the conditional probability of death. And once the shape of this curve is determined, then the method used concepts similar to Cox proportional hazard modeling, which would then scale this reference curve to the individual studies included in our analysis using random effects as well as covariates. Here is the non-mem code highlight for the Turner method. So these expressions are actually repeated over every single month interval in our analysis, but I cut it down to just the first three for the sake of brevity. So like David already kind of mentioned, the theta 1, the first fixed effects, is defined as a logic transform survival probability at the first time point, in this case, the first month. X2 as well as further X3, X4, etc., is defined as a logic transform survival probability at subsequent time points. Theta 2 in this case is a difference in the logic transform survival probability between 2 months and 1 month. So each of the subsequent thetas will be the difference in survival probability between the current month and the prior time point. This allows us to then derive the expressions for the reference survival curve, and we use an inverse logic function to get the survival probability. Other kind of pieces of the code to highlight is, like I mentioned, there's like the Cox proportional hazard model, which scales that reference curve to the individual studies. And so this is the expression here, the log hazard ratio, which is expressed as the linear combination of the random effects as well as the covariates. Once you get this hazard ratio term, you can then scale the survival curve to the individual curves in the study. And that's highlighted in the blue box. And then lastly, the green box is calculating the conditional probability of death. So here is just a snippet from the Lee 2017 paper that I mentioned, the individual level meta-analysis, which identified several key prognostic factors, which we use to guide our analysis as well, such as sex, performance status, age, histological subtype, etc. So next I'll be going over the results of the analysis. First, this is all of the literature studies that were included in our database. And our analysis included summary level data from 26 historical trials, which included 41 arms and 37 participants. In the top right table, you can see all the drugs, the individual chemotherapy agents that were included in the analysis. In the bottom table, it summarizes the demographic characteristics. And I want to point out that this is summary level demographics and not individual level. So for example, instead of the actual number of males in our data set, it would be the percentage of males for each of these individual studies. Similarly for ECOG, it wouldn't be the individual ECOG score for the patients, but it'd be the percentage of ECOG form status 0, 1, or greater than 2 in each of these various studies, because again, it's summary level data. Here are the digitized OS Kaplan-Meier curves from all the various different literature studies. One thing you might note is the time points all line up because the same time points were digitized. And it includes like quite a bit of drugs. It includes gemcitabine or vinorelbine, which there's our two green curves. They're both gemcitabine or vinorelbine. Is quite difficult to see, but one of the curves is the Ipsos trial, but in addition it includes another trial, O'Brien, that also used a similar chemotherapy regimen as Ipsos trial. But in addition, it includes many other different drugs as well. So to, like mention the methods, we want to get an idea of what baseline prognostic factor would likely have the most impact. And so using the covariate estimates from the LEAD 2017 paper, we calculate the risk coefficient for ECOG, for sex, for histological subtype, as well as cancer stage. And the idea is if it has a large risk coefficient, it'll likely be an influential covariate in our analysis as well. And so each of the covariate risk coefficients are color-coded by different colors. And this is a very qualitative assessment, but you can see that just based on this graph, that ECOG score greater than or equal to 2 or coded as ECOG 2 on this graph will likely have the biggest impact if it has the bar with the largest magnitude. So when we implemented ECOG on the model, it was the only significant covariate in the final model. And we did test other covariates such as age, sex, disease stage, squamous versus non-squamous, adenocarcinoma versus non-adenocarcinoma, and Asia versus non-Asia geographic region. But none of these had a significant effect on the hazard ratio. After adjusting the ECOG performance status to be the same as the Ipsos control arm to allow an apples-to-apples comparison, the hazard ratio between the Ipsos control arm and historical trials was 0.531 with a 95% confidence interval of 0.424 to 0.664. So this clearly shows that the Ipsos control arm is non-inferior to the historical trials, meaning all the other treatments grouped together. The plot on the right illustrates this. The plot on the right is on the y-axis, we have the overall survival, and the x is the time in months. The yellow is the historical trials adjusted to have the same ECOG distribution as Ipsos. The blue ribbon is the 90% confidence interval, and the green line is the Ipsos control trial. And you can clearly see that the Ipsos control is not only non-inferior, but it shows somewhat, I would say, benefit over historical trials. Here are the final model parameters. Like mentioned, many of the data estimated were the logic transform differences between between different month time points. But there's 3 parameters I wanted to highlight. The first is the Ipsos control arm effect, and the value is negative 0.633, which means that if patients were part of the Ipsos control arm, they had a lower hazard as compared to the historical trials. For the ECOG greater than 2 effect, it's positive 0.769, which means that if patients had higher ECOG performance status, they would have higher hazard. And for ECOG 1, and the effect is quite small, since the reference ECOG for both the ECOG greater than 2 and ECOG 1 is ECOG 0. So ECOG 1 is a slightly worse status than ECOG 0. The effect size is quite small, 0.004. Here are the model diagnostics showing the model fit of the observed versus predicted for the final model 010. The blue line is the typical value, the population OS curve, and the gold is the individual predicted OS curve. And for the most part, the observed data matched the predicted well with no systematic bias. So now that we have this final model, we want to do some other additional comparisons to get further understanding of not only how the Ipsos control arm would compare, but also the Ipsos active atezo arm. So in this table, there's 3 different comparisons. First is comparing both the Ipsos control and the Ipsos atezo with the grouped historical controls. Then the middle row is comparing both Ipsos control as well as the Ipsos active atezo with the NCCN recommendation. And then the last one is for comparing with the ESMO grouped recommendations. And across all evaluations, it showed non-inferiority of the Ipsos control arm, as well as the benefit of atezo as compared to the historical trials. And these results support the observed benefit of atezolizumab in the Ipsos population. So now, I'll be going over some of the conclusions, and hopefully we'll have some time at the end to take any questions. First, the ECOG performance status was the only statistically significant covariate that was identified in our analysis. After adjusting for ECOG performance status, the model predicted hazard ratio for the Ipsos control arm relative to historic trials was 0.543 with a 95% confidence interval ranging from 0.435 to 0.677. The hazard ratio for the Ipsos atezo monotherapy arm relative to historic trials was 0.418 with a 95% confidence interval ranging from 0.335 to 0.522. And so overall, the results of the model-based meta-analysis is consistent and supports the clinical benefit that we saw in the Ipsos trial. There are several key limitations I want to note. The first important one is that many of the studies that were included in the database were published 10 years ago. The Ipsos trial, that trial read out around 2023, so that was a much more recent trial. A lot of times, and it's an inherent limitation with these historical retrospective comparisons, is that a lot of times there could be improvements in medical treatment that are not captured by the intervention. And so more recent trials, therapies in general could have longer survival just because there are other medical supportive treatments that could extend patient life. So that is one key limitation I wanted to point out. Another limitation is while we did do covariate analysis to try to adjust for cross-trial comparison, there still could always be unknown sources of heterogeneity. Another one I want to note is that we evaluate histology as a significant covariate, but one thing that should be noted is the pemetrexed treatment is normally only appropriate for non-squamous cell patients only. So with that, that concludes my presentation today, and I believe next we'll be transitioning to the Q&A, and excited to engage with the audience with various questions. Thank you.
Great. Thank you, Joseph. Thank you, David. At this point, let me open the floor to questions here. I have a couple here. So the first question is a question for David. Would you expect a durability boost for PD-1?
Would I expect a durability boost?
Yes.
I think relative to chemotherapy, perhaps, yes. I think that's one of the unique nature of the response for PD-1 inhibitors and IO in general is that compared to chemo, where you see often very deep but transient responses, what we see more frequently with immunotherapy agents is that they do achieve maybe a similar response, but it's much more durable in nature. And so I think a lot of people question the linkages between response rate and OS across different treatment modalities.
Mm-hmm.
It's not that there's not a correlation, but just that the correlation's different and it depends on the treatment modality. So we try to incorporate that into our meta-analysis.
Okay. And would you expect similar behavior for other PD-1 drugs, other classes of drugs, or other tumor types? Can you comment on that?
I could probably only speculate. So obviously our scope was very focused on PD-1 inhibitors, Nivo and Pembro, at least at the outset. And like I mentioned, I think the framework is still being expanded to other different treatment types. But in general, there have been numerous publications on this phenomena that there are different patterns of response with IO treatments in general. And so Yeah, again, I could just speculate that it probably would extend to other types of IO treatments and other treatment spaces as well.
Thank you. Does the MBMA account for data quality, for example, study size?
Yeah,
It does. Yeah, maybe someone else, Joseph.
Oh, okay. So maybe I can address for the case example, and then David, you can also talk about it as well. I know and maybe Russ can also comment, but I don't believe that we had anything, or apologies for the log likelihood equation, Russ. There is a weighting for the number of patients in the study. Is that correct, Russ?
Russ, you might be on mute.
I'm not on mute.
Here you go.
So there was a accounting for a number of people who were in the study, as well as the number of people who had died in the different arms in the likelihood equation. Yes.
Thank you. Another question, technical one. What are digitized KM curves?
Yeah, that's a great question, and I probably should have explained better. It's to put in the most simple way, it's taking the picture from a publication of a Kaplan-Meier overall survival curve, and since you're just looking at a picture, you need to transform it into a data set for you to do analysis. For example, the overall survival at 1 month, at 2 months, at 3 months. So it's simply using software that extracts that data from a picture.
Great. Have you included data of study as a covariate?
That's a great question as well. I didn't want to go into it in specific in this presentation since there's a lot to unpack. But we did evaluate date as a covariate, and it wasn't significant. We did some other sort of, we're working on a manuscript for this work now, and we've done some other additional comparisons to see the effect of publication year, and it's not so clear whether or not we truly controlled for time effect, but for evaluating date as a covariate, that evaluation, the date wasn't significant.
Yeah, so I think the thinking here is that standards of care may change over time too. So you may see different things in older studies as the standard of care evolve. Does the use of chemo include standard dose, low dose, ultra low dose, or just conventional chemo doses?
So we didn't include dose as something that we identified during the literature search. But Russ, do you recall if there's if any of the studies were separated by low dose? I believe it was just the standard, it was the standard dosing regimen for that indication in that patient population, right? There wasn't any sort of dose variation.
I don't remember any special heading for low dose or high dose.
Okay. Another question. Is there any reason why you used the Turner method rather than a parametric hazard model?
Russ, do you think you could take that one?
Maybe I can even take a first stab at just kind of the basic assumptions here. So the method that Joseph is alluding to, the method that Russ and I originally published, is actually a semi-parametric method. So it's more like a Cox proportional hazards model. And I think the advantage of such a model is it gives you a flexible baseline hazard function. Right. Often we're not very interested in the baseline hazard, but we're interested in relative treatment effects. And you can apply a parametric model. I don't think there's anything that would stop you from doing so, but sometimes the assumptions that you place on the shape of the underlying baseline hazard can be wrong. And that can actually do more danger than the benefit it gets you when you're not necessarily extrapolating beyond the existing reference curve. So yeah, I think there's a lot of advantages of having a flexible reference survival curve that you can then scale in a parametric fashion based on your set of covariates.
Great. Was there any weighting of the variability in the logit space performed?
I think so, Russ, right? We accounted for the number of patients alive across different intervals, if you recall. we had a sort of an implicit calculation in there because in the tails of the curves, right, it becomes a little bit more sparse. And so we basically accounted for the information that was earlier in the survival curve when we have more data. So we had some expression there accounted for the number of patients alive.
Yeah, I don't think there was any specific variability in the logit scale. So there was the same amount of variability at low logit versus high logit. And it was accounting for size of the study and number of subjects still in the study.
Okay. Another question is, in your database, do these studies have biomarkers in addition to survival and tumor size, et cetera?
David, I don't remember that we thought about. Well, I guess
we consider this, yeah. The studies often do have biomarkers, but I would say they're more inconsistently reported compared to just traditional, oncology efficacy endpoints. And
yeah,
it's something that could be explored, I think, in future work. But obviously, there's, it's always challenging to associate a biomarker with an outcome. And I think the challenges become more so when you start talking about integrating the data across different studies in a meta-analysis.
okay. Practical question, is the software available? And is it free or is it a commercial?
So the modeling was done in non-mem, but for the digitization software, I believe Phyllis mentioned there's something in GitHub that can enable digitization. Is that right, Phyllis?
What was the software used for the Ipsos analysis?
I'm sorry, can you repeat that? The first part of your sentence got cut off.
So the software that's posted in the answer, that's the one used for the Ipsos analysis. So if it's on GitHub, I'm pretty sure it's free.
Great, thank you. Another question, was wondering if the ORR to OS predictions work in lung cancer because the initial tumor and disease progression occurs in the same organ. Well, would that also be the case when you have a situation where tumors metastasize to different organs than the organ of origin? And often that's the one that is fatal. Interested to hear you guys' thoughts on this.
So the data set that we were dealing with, Russ, was metastatic mNSCLC. So these are patients that had target lesions interspersed in different organs. So just to challenge that assumption, and sometimes, and even in lung cancer, you have metastasis, right? And this particular setting was metastatic mNSCLC. That said, right, ORR is a measure of the target lesion growth. And so there is a disconnect sometimes where sometimes the target lesion growth doesn't predict overall survival. But I think in general, what we see in lung cancer, there is a fairly strong correlation. In other tumor types, that correlation may be stronger or weaker, depending on what's the actual driver on death. So yeah, it very well could be different across different tumor types.
Okay. Another question, if I understand correctly, the tumor model also relies on a proportionality assumption. How did you check for it? And do you have any recommendations for how best to do that?
You want to take that one, Russ?
Not really. I don't think we checked for proportionality. In general, after we made the predictions, we would overlay the modeled survival curve with the observed and see if there were any deviations, any consistent deviations. And if they aligned pretty closely, we felt it was doing a pretty good job. But we didn't check for proportionality.
I do remember it was a question that had come up, right, when we were developing the models. So it was something that we wanted to look at in the end. Like you said, we I didn't show the plots here, but we did some sort of goodness of fit plots where we actually predicted hazard ratios from different trials, and I think the predicted versus observed plots, they were in general agreement. We didn't see a lot of deviation that would indicate non-proportionality, but it's not to say you couldn't include that, right? You could include a non-proportional hazard. You can include a time-dependent hazard function within the model. It's just that we didn't in our particular case.
Okay. Another question, since exposure was not accounted for in the model, is this approach applicable when you have other standards of care which have a flat exposure response relationship, for example?
So I think I'm reading the question, and I think the person asking was because I think in drugs in which there's a flat exposure response, I feel like this method would work really well. I think in situations where there's more steep exposure response relationship, we would have to probably account for other things. Like in both of our analysis, we didn't account for exposure or dose or anything. And I think if there was exposure response, we would have to somehow account for that. So yeah, that's probably the best I can answer it.
Yeah, I turned that question the other way around. It's you're right. If it's a bigger, steeper curve, you might have to account for that more.
And also for MBMA in general, I think if typically the data or studies we include in the list of data sets included, we typically include the data that are coming from the approved doses. But if you do want to include data from earlier trials where you have testing different dose levels, then potentially you could include like a dose response into the model as well.
Okay. So this one, I may need your help in interpreting the question. So Ipsos control arm was found to be superior compared to the NCCN and ESMO guideline arms. Is there a particular reason for it? And did you compare individual drugs versus Ipsos control arm?
Thank you. This is actually a very good question, but also a little bit difficult to unpack. So we did do comparisons with each individual therapy, and the confidence intervals, the point estimates did show that the Ipsos control arm was mostly was better, but the confidence intervals included one. So the analysis question initially was just to see if the control arm was non-inferior. So I think. So the question is why do we think it was superior to NCC and ESMO? Yeah, I'm not sure. I think what we really just wanted to show why this is not inferior. Why it was superior? Again, it could be that there could be unknown sources of heterogeneity that we didn't account for. The time component could be a factor. These are all different things that we need to try to unpack as we look into the analysis deeper. But for the most part, it at least shows that it's not inferior.
Okay. And then I'll finish up with one of my questions, which is around communication of modeling results to decision makers. Who's the intended target audience for this kind of analysis? Is it people that are designing clinical trials, or is it people making treatment decisions at the regulatory level or the insurance companies? Who are you targeting, and how do you communicate differently to the different people that might use these results?
And I would be speaking for my other panelists, so feel free to jump in. But I think the stretch goal or the ultimate goal is eventually for regulatory acceptance of these sorts of analysis. I think in this point in time, there is a little bit more hesitancy to accept this sort of analysis over actual clinical trial data. So I think that's the hope of these sorts of webinars and continual engagement can get the community more familiar with these sorts of methods. Oftentimes in practical communication, we have to communicate the results to the study teams, people who are non-technical, who are, trying to understand how this matters within clinical practices within the scope of drug development. So I would say at this current time, a lot of the audience are kind of non-technical folk, but
Mhm.
I don't know if other people want to comment.
Yeah, I think the way we placed our analysis was an internal decision-making tool,
Okay.
aspirationally, right, a regulatory tool, but I don't think we're quite there yet in convincing health authorities. But in general, the meta-analyses that I've seen and that have been applied have been internal decision-making tools.
All right. Well, thank you very much to the panelists for the presentation and for following up with a good question and answer session. I'd like to remind the audience to check the website for upcoming webinars. And thank you for joining today and enjoy the rest of your day. Bye-bye.